acid reflux is just, I guess if I ate a little bit more hot sauce, but this coffee ought to do it. I don't know what makes this happen. You know, acid reflux, they say stop doing and eating the wrong foods. I mean, I'm only drinking coffee. How much acid could that have? Squeeze lemon over my toast. And I'm eating bread. You know, I'm trying to keep my cholesterol down, but I just love these buns right here. Surely this is great. Great rolls. Oh, it's just so sweet. More coffee. I used to eat a whole bag. Now I'm down to 2 a day. Thanks for Great Age Movement. They're going to teach me about my health today. Come join me. Let's stream with Great Age Movement. No more cholesterol, hernias, or high beast. High eating wrong. Acid reflux.
Okay.
Hi, and happy Saturday. Welcome to the Great Age Movement at Home Lab Series in partnership with the Health Museum. Today, we are talking about reflux, hernia, and obesity with my friend here, Dr. Victoria Chang. She's a general surgeon and bariatric surgeon.
That's right.
Welcome to the show.
Well, thank you for having me, Fritz. As you mentioned, I'm a general and bariatric surgeon. So I do a lot of weight loss surgery, but I also do a lot of general surgery, which includes things like reflux surgery, hernia surgery, colon surgery, stomach surgery, anything in the belly, you name it. Even some soft tissue things like any skin, like lesions, lumps or bumps, lipomas, cysts, things like that.
A
little bit of everything.
Something I have on my arm.
Oh, okay, yeah. Cut that right out.
Well, and I think a lot of people, especially seniors, there's a little bit of apprehension when it comes to surgery. And I thought it was a great idea for one of our shows to talk about some of the things that people experience. And a lot of these conditions that we just mentioned, reflux, hernia, and obesity, happen along the entire spectrum of adulthood. And so I thought it'd be nice for you to enlighten people about like the mechanisms, how it all happens, and what you can do about it.
That's right.
So let's start with the reflux. I know I
Sure.
get that occasionally from coffee, and sometimes red wine does it. So I had to eliminate that from my drink. So tell me about reflux.
So these 3 topics that we've chosen are particularly special interests of mine. So I'm happy to share my experience and how these things happen and how you can treat them. Not only, I'm a surgeon, but there are different options of treating each of these things, including lifestyle changes and medication. So first off with reflux. Now, reflux, hernias, and obesity, these things are all sort of related, and I'll kind of go into more detail of that later on. But reflux, as you mentioned, there's some things. So reflux itself is a phenomenon that can happen based on, depending on whenever the valve mechanism between your esophagus and stomach is disrupted and allows your stomach acid to reflux up into the esophagus. Now, people without reflux disease can still experience reflux, and it can be brought on by particularly acidic things or anything that causes the stomach to really distend and pull open that valve and allow acid to reflux up into the esophagus. Now, when reflux becomes a disease, when does it become a disease? It becomes a disease when patients experience frequent symptoms and it's disrupted to their life. And we're talking about, at least 2-3 times a week. And not only is it based on symptom frequency, but also any complications that can occur from long-term reflux. Now, reflux is the most common GI disorder in the elderly population, and it's particularly concerning in the elderly population because as people get older, they have decreased sensation of the heartburn symptoms, the typical heartburn symptoms and regurgitation symptoms that most people would feel. So because of that decreased sensation of these things are happening, elderly patients can have more progressive disease than, say, a young adult or whatever. And when I say progressive disease, I'm talking about, so what reflux does is the acid burns the lining of your esophagus, and that's what causes the pain. And when the reflux tracks all the way up to your throat. That's what people feel is regurgitation of acid. And it becomes a complication when the chronic acid exposure causes inflammation, erosion of the esophageal lining. And chronic erosion and inflammation of the esophageal lining can cause esophageal strictures. A stricture is a narrowing. It's where the inflammation is so bad that that area of the esophagus narrows down.
Does that usually happen close to the valve that connects to the stomach?
Exactly, yeah. It usually happens close to the valve, and people feel that they have a difficult time passing food.
Okay.
The other particularly important complication from reflux is esophageal cancer. So decades ago, when smoking was, everybody was the thing and everybody was doing it, there was a particular type of esophageal cancer that was related to smoking called squamous cell carcinoma. But now that smoking has kind of gone away and people have, we've done a good job as a society of getting people to not smoke. Now we're seeing more and more esophageal cancer related to reflux disease, and that's esophageal adenocarcinoma. And so the reason, many people think of reflux as this sort of benign thing. It's like hypertension. Oh, we just take a medicine and get rid of it.
That's it. Stabilize the condition.
Exactly. But what a lot of people don't realize is that chronic reflux can lead to dangerous things like esophageal cancer. And you can even get something even if you don't get esophageal cancer, you can get something called Barrett's esophagus, which is a precancerous lesion. And for us in the medical specialty, that's an alarming sign that we need to do, that this reflux is bad enough that we need to do something about it. And that's when we start thinking about surgery or increasing your medication dosage. And if the medicine isn't helping, then we really start considering surgery.
Which is ultimately the last step.
It's the last step. It's the definitive treatment for reflux. And so when reflux is pretty mild, there are different things that you can do to mitigate those symptoms. And like you talked about, cutting out certain foods and certain liquids, caffeine, chocolates, spicy foods. Yes.
Oh no!
I know. So, and then anything that can also delay the stomach from emptying and cause it to be distended. Like I mentioned earlier, when it's distended, it opens up that valve and allows acid to reflux up. So things like fatty foods, which tend to delay gastric emptying.
Let me ask you this, like also, there's always a rule to chewing. If you don't chew your food to smaller pieces, do you think the size of that can also damage the valve as it enters the stomach if it's too big?
Could be. It's not something that we usually talk about or recommend, so I don't know if it's been well studied, but I could see how that could happen.
Yeah.
The thing that I see most likely happening with something like that is if you don't take the time to chew your food and you just kind of inhale your food, you may overeat and again cause that gastric distension, which may disrupt that valve mechanism. Yeah, and I think I've talked about most. Oh yeah, so lifestyle modifications, weight loss is definitely an important component of lifestyle modification with reflux because obesity is associated with reflux disease because of that increased abdominal pressure from the excess weight. And when lifestyle modifications don't work, we also give prescribed medications, PPIs, proton pump inhibitors. And we try that for a period of time. And a lot of patients have good control of their symptoms with just medications. There's going to be a subset of patients who don't have good control, even with medication, even with escalation of medication. And in those patients, we start talking about, interventions such as surgery to recreate that valve mechanism. And if there's a hiatal hernia, we repair that as well.
Yeah, interesting. So is there like so when you're doing the surgery and you say you have to manipulate it, are you also having to use other sources to make up for something that's been damaged or removed?
No, there's the valve mechanism is usually what's been damaged in reflux disease, and it could be damaged from a hiatal hernia being present, or it could be disrupted just because it just isn't the muscle isn't strong enough to prevent the acid from refluxing back up. Either way, the surgical treatment, the traditional surgical management of reflux disease is with the stomach wrap or fundoplication, where we just take the top of the stomach and wrap it around the lower esophagus. to kind of recreate that valve
I
mechanism.
could totally visualize. That's interesting.
Yeah, and we usually combine it with a hiatal hernia repair because a lot of times these patients have a hiatal hernia, which again allows the top of the stomach to herniate up into the chest.
So if you do that surgery, you lose a little bit of the surface area of the stomach.
You do.
So you're not consuming as much.
You're right, and that's a really good observation, Fritz, because there are a lot of people who do lose some weight after fundoplication surgery, just because, like you said, the capacity is lower.
What percentage of surgeries result in that when it's at the point of surgery? When you wrap it versus other treatments that you do?
Oh, what percent of patients end up seeking surgery?
Yeah.
Oh, very few. I would say less than, and we've looked into this because I'm developing a reflux program right now at one of my hospitals, but less than 1% of patients with reflux seek surgery.
Okay.
And a component of that, maybe just that they have good control with medications. And a component of that is just that they don't know.
Yeah.
And their primary care providers aren't talking to them about it. So it's just part of it is a lack of awareness about it.
Sure.
Mhm.
It sounds like interdisciplinary approach is so important.
Oh, definitely.
So that you're not just relying on medicine that could eventually lead to needing surgery without changing, like you said earlier, like the foods and the drinks, and also, exercise and fitness. Yeah, it seems like it all works together.
Definitely.
Very enlightening.
Yeah, so maybe we should talk about the next topic, hernias.
Yes,
Since you talked about, since you brought up exercise and all that. So,
and there's more than one kind.
yes, and I mentioned one, which is a hiatal hernia, which is a hernia defect through the diaphragm. There's also other one. Your diaphragm is a muscle that cuts across your body like this. It separates your chest cavity from your abdominal cavity. There's also abdominal wall hernias. So you may have heard or seen some people with a lump of varying sizes on their abdominal wall. So it can be from, so there are two types of hernias. There are primary hernias and there are incisional hernias. So primary hernias are hernias that just kind of pop out of nowhere. Who knows what happened? Maybe it's some straining, maybe too much heavy lifting, and there's a genetic component to it. There's a lifestyle component to it of why it's multifactorial, why people develop hernias. It's genetic in terms of the quality of your connective tissue. And certainly as patients get older, those tissues get weaker and weaker. So I see a lot of hernias that develop later on in life in my patients, especially inguinal hernias, which is another type of hernia in the groin area on the right or left side. So in those kind of patients, there's no data showing that exercise or activity causes hernias.
Okay.
The other type of hernia is an incisional hernia. So if you've had prior abdominal surgery, the incision site, after it's healed, it's never 100% the same as if you had never cut through it in the first place.
So it's that scarring that ends up happening that's not stronger than the actual
muscles or original tissue. It's probably about 80% the original strength.
I didn't know that. That's
So when people get hernias, most of the time when people have hernias, they've had prior operations and they have a hernia through that incision site. Activity levels never been shown to cause hernias. But
this is what people often say, because I did something exercise related or lifting that ultimately resulted in a hernia.
Yeah, and I've heard
they
that.
They believe, but they don't know because many things are happening.
And a lot of things could be happening, exactly. I certainly, I'm sure it can contribute to it, but I don't, there's nothing that shows that it is the cause of hernias. Certainly once a hernia forms, patients should take caution to not, because once a hernia forms, it doesn't go away. There's no medicine to make it go away. The only treatment for it is surgical repair.
Does it, so like you were saying, some of it, like part of it can come out like the mesenchyme or the intestines, and does continuing not to do anything about it, does it keep coming more out?
It can. It can stay the same or it can get worse, but it will never get better.
Okay.
But yeah, the things that herniate through are typically intra-abdominal contents, such as your intra-abdominal fat, the mesentery, like you were saying, or if it's a big enough hernia, even a piece of intestine or other organs.
Which could definitely affect the flow of the food being processed.
Exactly. Another great observation.
So what comes out of that if it does get trapped?
Kinked up like that. So like I said, the only treatment for hernias is surgical repair. Now, patients can elect to just kind of watchfully wait, see what happens. And especially if they have no symptoms from it whatsoever, no pain, no signs of obstruction, everything's moving through smoothly. They can certainly just wait and see what happens and not do anything with it. I do counsel patients on looking out for alarm symptoms, which are pain at the hernia site, especially severe pain, any redness or changes in the skin overlying the hernia, as well as obstructive symptoms. So like you said, if a piece of intestine gets caught up there, and most of the time, patients do fine with a loop of intestine in the hernia. They don't have obstructive symptoms, but occasionally someone will develop an obstructive symptom where a whole lot of intestine has gotten trapped in there and it's kinked off right at the neck of the hernia. And what usually happens is they'll say, I haven't pooped in or passed gas in several days. And now I feel really bloated. And they come to the hospital and they come in with a small bowel obstruction. And that's an alarming symptom because that's when we consider the hernia to be incarcerated, which can be dangerous because the blood flow to the intestine can be compromised and therefore the intestine could actually die in the hernia.
Oh, wow.
And that becomes very dangerous for the patient.
Yeah, like septic or something. It
Like
starts to back up.
When there's an obstruction, your gastrointestinal contents start to back up. But when there's sepsis from that segment of the small intestine dying, you get perforation, you get necrosis inside the hernia, and that can be very dangerous.
So this is just a side note, like, why do you think people are so fearful of surgery, especially when something like that becomes so alarmingly dangerous?
Yeah, so a lot of people, I totally understand it. I've been through surgery myself, and sometimes I get a little nervous about it, even though I know people, I've done surgery and I know everybody does fine, but I think it's the concept of letting go, especially most people are scared of the anesthesia, not necessarily the surgery part. Most of my patients, a lot of my patients will say, Doc, just make sure I come back out of anesthesia. And most people are just scared of the anesthesia part, and because they're worried about, not coming back out of it. They probably watched a lot of TV shows or movies that, talk about them.
Or they heard through a friend that their surgery went bad.
Exactly. But, our job as surgeons is not just to cut on people. The toughest part about surgery is managing the patient around the surgery, not necessarily the surgery itself. The toughest part of surgery is making sure the patient is perfectly optimized to be able to undergo anesthesia. We don't just offer, surgery to anybody and everybody. If somebody's got bad uncontrolled diabetes, they've got heart issues, lung issues, or whatever, we are going to have them see all the different specialties that they need to see to get them optimized for surgery. Now, if you're healthy, you don't have any medical problems, you should be able to undergo anesthesia, no problems at all.
So you're looking at the whole medical picture before it's decided.
Exactly.
That's good that you're saying this, that you just don't jump in and just trying to cut into people.
Oh, yeah.
By the way, the first time, because you went through a lot of training to become a surgeon, what was like the first time you had to cut into somebody? That just seems so, the sound and all that. Did you feel this, were you overwhelmed like the first time?
No, you know what? It was very odd. Really the first time I had to cut into anything or into somebody was in my anatomy class, and that was a cadaver. But the first time I had to cut into a living human person was as a medical student in my third year rotation, and certainly I wasn't operating on my own. I had my attending surgeon and everybody kind of like monitoring every move. But that was the first time I ever cut into anybody, and it really didn't faze me, which was interesting.
Yeah. Well, I think because, like you said, you took a cadaver course, so you started preparing yourself.
Exactly.
I'm sure it's like it's somebody's life, so I'm sure you're extra attentive to making sure it all comes out perfectly.
Oh yes.
They're counting on you.
And
it's life changing.
As I progressed through my training, that feeling of this person's in their life is in my hands. As I got more independence through my training, that feeling became stronger and stronger.
And I think people hearing that, they feel more reassured because it's easy to forget all you've done to get here.
Oh yes.
But the end result is just life changing for people.
It is, and that's why I chose surgery, is because it's you see the instant change in people's lives. You have this patient who came in ill or uncomfortable from something, and the next day after surgery, they're like 180, it's 180 degrees, difference for them. But yeah, you're right. Our first rule of thumb as physicians is do no harm.
Yeah. Let me ask you this. So let's say, what is a standard surgery amount of time, like for an inguinal hernia
Yeah. So,
Are these like outpatient procedures?
so hernia surgeries are usually outpatient procedures. So that means you get your surgery that day, you go home the same day. Usually you spend a couple hours or so in recovery just to make sure, further monitor that you're okay and that you're
Anesthesia's
safe for
gone.
discharge. Anesthesia is mostly gone. Anesthesia will still be in your system for the rest of the day. So that's why they always recommend that somebody drives you home. But from a clinical stability, vitals, from your standpoint of your vitals and how stable you appear, we monitor that for a few hours after surgery before we send you home in an outpatient setting. Reflux surgery is usually an overnight procedure. So I'll do surgery on somebody and then they'll stay overnight and go home the next morning. The other topic that we didn't get to is obesity.
Yes,
now that's
a
also
big one.
that's
And
also
still, I feel like society has definitely improved on health and exercising. It's so common these days. Here we're doing it on the show on weekends. Here for people at home to exercise. But I feel like well, it's still an issue. It's a pretty big issue. And so, could you elaborate about obesity itself and like how is it defined in medical terms?
Yes.
Obesity?
So obesity is, like you said, obese. I mean, for recently, thank goodness, society, we've put a lot more emphasis on health, eating well, exercise. But until recently, obesity, and it still is, obesity is an epidemic in our society. Before COVID, we had an epidemic of obesity in the United States, where 40% of Americans was considered obese, 60% of Americans were considered overweight or obese.
How is obesity defined? Like, how
right,
and
so we define it by calculating the person's body mass index or BMI. All physicians screen, or at least primary care physicians should be screening their patients by checking their BMI, which is a ratio of your weight to your height. It's not just based on your weight because weight by itself doesn't really tell us a whole lot unless we compare it to how tall you are. Because you can be really tall and slightly heavier, or you can be really short and heavy. And if you're short and heavy, that makes a big difference.
Sure.
So a BMI of 30 or above is considered obese. A BMI of 25 to 29.9
This
is
is the percentage of being over your ideal body weight?
no, this is just a ratio of your weight to your height.
Got it.
And so yeah, BMI of 30 or above is considered obese. BMI of 25 to 29.9 or between 25 and 30 is considered overweight. A normal BMI is somewhere between 18 and 25. So, obesity is important not only because it's such an epidemic in our country, but also it's very costly, not only on the country, the healthcare system, but even on a personal level. All the medical problems that are associated with obesity, hypertension, diabetes, cholesterol, reflux, hernias, osteoarthritis, right? Joint problems. A lot of patients, especially as they get older, will start feeling joint problems. And if they're obese on top of that, it makes it worse. And they'll go see an orthopedic surgeon thinking, I'll just get my joint replaced. And then their orthopedic surgeon will say, no. Many, many orthopedic surgeons now are not offering joint replacement surgery if they're above a BMI of some number. So they usually recommend weight loss prior to those surgeries.
You really have to put some effort in before you go and say, I need surgery.
Right, exactly. Yeah. So yeah, it's costly for the individual, not only because of the cost of medications they have to take that because of the medical problems associated with obesity, but it could also increase cost of hospitalizations. If they get sick, they have more propensity to get sick from those medical complications. They are at higher risk of getting complications from just routine operations like joint replacements, like an appendectomy, like a cholecystectomy. Obese patients have been studied and known to be at higher risk of complications. And in fact, I recently posted online that heart failure is also associated with obesity. And if the heart failure, in some patients with bad enough heart failure need heart transplant. And some patients cannot be listed for heart transplant if their BMI is above a certain level. Because again, you're getting a heart is being donated. The surgeons want to make sure that heart goes on for a long time in another person. And obesity is associated with increased risk of complications after a heart transplant surgery. So they don't want that organ to go to waste.
And so at that point, when you have the heart failure and you have the obesity, it's much harder to try to lose that weight through exercise.
Exactly.
Your heart can't
keep up.
Yeah, exactly.
Yeah, you're right. You're right.
So it's very much connected to all these conditions.
It's a
Yeah.
systemic disease, and some people think of obesity as purely a superficial weight problem, but it's
Yeah.
not. It's a systemic metabolic syndrome.
Yeah.
It's a systemic disease. And obviously, the way we treat with obesity is obviously lifestyle changes. We try to start with that. Recommend diet, proper diet habits, visits with the nutritionist to learn healthy eating habits.
Yeah.
Um,
I feel like the nutritionist is underutilized in the healthcare system.
oh, definitely.
Yeah, because you're given a medicine, suddenly I don't have my problem anymore, but you never really address the problem outside of stabilizing it.
Yes.
So the nutritionist, 'cause a lot of people don't know what they have to eat.
You're right.
Know? And if somebody breaks it down for them, just like when you go to the gym, somebody breaks down how to exercise, I think they need the same thing with food.
Oh, for sure. No,
Yeah.
I think I totally agree with that. I think the offer in terms of a lot of physicians don't know either, because we spend all of our medical education learning and how to save someone in a emergent dying sick setting. But for that setting, in terms of like wellness and overall health, we don't get a whole lot of teaching about that, and that's where I think
you can't be a
nutrition has a lot
specialist
to
at
offer.
everything. So that's why you have a good big team that works with that patient.
Exactly. And even just these exercises that you're doing weekly are fantastic, of things that are available to get people moving, be more active, live a less sedentary lifestyle. So we need people like you too, who aren't just focused on because I'm focused on prescribing medications and seeing sick patients, but we need people and providers outside of that to fill the other gaps that we can't fill. Now, apart from the difficult thing with obesity is that once someone gets to the point of obesity, it is very difficult to lose the weight, and that's why we call obesity a disease. It's not that being overweight and healthy, unhealthy eating habits is a disease. It's that when something has progressed, when the metabolism can't keep up with those eating habits anymore, that's when it becomes a disease. So that's why obesity is a disease, because the metabolism is at that point deranged and cannot, it's out of control. And so that's why we offer treatments like medications or surgery. And that's because, at that point, lifestyle changes they're very, very difficult in getting someone out of the obese range. In fact, so our studies show that 95% of patients, once they've reached the point of obesity, are unable to sustain long-term, effective, durable weight loss. And that's why surgery in obese patients is actually considered to be the most effective and durable option for obesity.
So what are some of those surgeries that people do at that point? It's all related to the stomach, right?
Yes. Okay. So and the small intestine, but there are really 4 options for bariatric surgery nowadays. One of them is the gastric band, the sleeve, the bypass, and something called a duodenal switch. Really, most people nowadays get the sleeve and the bypass. That's most commonly what people get.
Like it goes over the intestine and compresses it? What's the sleeve?
A sleeve is where we cut out part of the stomach, and instead of this football-shaped stomach, we make a really long, slender stomach, like a sleeve.
Okay.
Yeah. And the bypass, it's a little bit of a complex procedure, but so the sleeve is mostly a restrictive operation where, obviously you've got a much smaller stomach, so you feel restriction.
Does that alter the breakdown of food when you remove some of the surface area of the stomach?
A little bit, not necessarily the breakdown of food, but the transit time of food.
Oh, okay.
Yeah, so because you got a much smaller stomach, the transit time of food is faster, exactly. But there are also metabolic and hormone changes that occur by removing that part, that 80% of the stomach that we do.
And do people have to take something for the lifetime supplements?
No. I'm sorry. In terms of vitamins, yes, we do recommend vitamin supplementation for the rest of
that
life.
was lost during the surgery.
It's just that there's decreased absorption of vitamins and minerals after bariatric surgery. And especially with the bypass, because the bypass, we we shrink down the stomach into a little pouch, and we rearrange the small intestine, where the food is bypassing the stomach as well as a portion of the small intestine. So there's a restrictive and a malabsorptive aspect to a bypass. Because of the malabsorptive aspect of the bypass, the vitamins are even more important with a bypass because there's even less absorption of vitamins and minerals. Both are very effective surgeries, and the way I decide, the way I recommend, whether somebody should get a sleeve or bypass is multifactorial. It's based on patient preference, obviously, and also their medical problems. So there are some people with certain histories that I think will not be appropriate for sleeve or won't be appropriate for a bypass. So it's I tailor it. So some examples are like we talked about earlier. If somebody has really bad reflux disease, I will tend not to recommend the sleeve because the reflux has been worsening of reflux has been associated with 20 to 30% of patients after a sleeve gastrectomy. So in those cases, I would tend to lean more towards the bypass.
Okay.
Now with the bypass, what kind of patients are what I think aren't appropriate for a bypass? So patients who are on chronic steroids for whatever reason, like they've got some autoimmune disorder where they need steroids all the time, or if they got really uncontrolled asthma or something that makes them need steroids all the time, then I would recommend no bypass for them just because steroids, anti-inflammatory medications like ibuprofen, Motrin, things like that, and smoking have been associated with marginal ulcers in the bypass, which can be dangerous. So if somebody's a smoker, I'll tend not to recommend the bypass to them.
You offer them the option if you quit smoking down the road, we can review it.
Yeah, I do.
Now, so once you have a surgery, how long does that take, by the way, if you do like a standard? I know it's different for every patient, but like if you do a bypass, how long does that take?
The surgery itself, it's like 1 to 2 hours.
Okay.
And you were asking about outpatient before. So most of my bariatric patients stay one night in the hospital.
Yes.
I do the surgery, they stay overnight, and they go home the next morning.
Okay.
Yeah, that's what happens. Maybe they might stay an extra day because of pain or nausea, but most of the patients go home after one night in the hospital. And most patients just take a week off of work too.
Oh yeah, I would think so. Yeah.
Yeah.
So once they have this surgery and say they lost 100 pounds, 200 pounds, obviously you may have built up the adipose in various parts of your body, the fat, and they start to have loose skin. Do you do surgeries to also accommodate the skin to the new body?
Yeah, so we often do. We kind of consider it as part of the continuity of care. Excess skin after rapid weight loss is very common. Yeah. It's hard to, and some people don't really have that much, and some people have a lot. It's really hard to tell who is going to have it and who isn't. But when they do have it, I usually try to recommend them to a plastic surgeon because they might have arms, a belly, and extra skin on the thighs. And if they're going to get that full makeover, I recommend a plastic surgeon. If they just want to get their stomach taken care of and maybe they can't find a plastic surgeon in their insurance network or that will take insurance that'll take care of them, I will offer, appendiculectomy where we get rid of that stomach excess skin.
Got it. Mm-hmm. Okay. And does insurance cover this bariatric surgery?
It depends on what plan was purchased. So every insurance company offers it, but it depends on what plan you purchase. So, if you purchase like the Cadillac plan of all insurances, then you're probably going to have bariatric coverage. But if you purchase like a lower level plan, it seems that they tend not to cover it. So, but these are things that, bariatric specialists like me, we have coordinators in our office who look into all that for our patients because I know it can be hard to navigate the insurance companies and the insurance world. And so we do that for all our patients. We screen their insurance companies for them to find out if they have benefits or not.
I think the most important thing is medical necessity.
Yes.
And I'm sure the insurance company looks at all the steps to get to the point of a necessary study.
Not necessarily. A lot of my patients, a lot of people have the medical necessity for it, but if they don't have that particular benefit included in their plan, their insurance company is not going to cover it. Mm-hmm. It's called an exclusion.
Interesting. So they rather take care of like 10 medical problems because of this, right?
Yes.
It's interesting.
Don't even get me started on that.
No, it's healthcare or insurance programs are just still a lot of work needs to be done.
Mm-hmm. No, definitely. I think it's because obesity is still, there's a lot of stigma around obesity as just a psychosocial behavioral problem.
It is,
like, oh, you brought it on yourself, but
But they put pressure like on fast food places because people like convenience, about the like the fats in the food. They've made some changes through legislation, but I mean, ultimately it's up to us to really take care of our bodies.
Oh, definitely, yeah.
So that's why we're now talking about Let's Talk Health. Dr. Victoria Chang, thank you so much. If anyone has questions, you can email greatag.com or
Follow me on Instagram, Dr. Victoria Chang. I'm also on Facebook. And,
what's
you
your
know,
email?
my email, I don't know if y'all are going to send it out, but it's victoriachangmd@gmail.com.
Yes. And we'll include that in our post after this.
Perfect.
Well, thank you. I think it's very enlightening. I think some people are afraid of surgeons, and it's nice to hear from a surgeon the steps involved. And she said, not just trying to cut into you, she wanted to give you the optimum care,
Yes.
and there's a process to it.
Mhm.
So I really do appreciate that.
Yeah.
Thank you, audience, for joining us. We'll see you next Saturday for another round of Great Age Movement at Home Lab Series. We hope you have a great weekend and take care.